I know we go over this quite often, but it's important. I think most of us understand it, but in case there's some of us that don't, we're just going to review. I'm going to try to share my screen with you. Can everybody see that? I can't see anybody, so if you can see it, can somebody say yes?
It's visible.
Okay, thanks. All
Yes.
right. So we're going to can somebody mute their screen? I'm echoing. Thank you. So alcohol withdrawal is considered a medical emergency, and your staff should be aware that if you are on site, they need to let you know right away if somebody's going to withdraw, and if not, they need to be calling the provider immediately. If somebody can walk in there and they're walking straight at a 0.25, that means they're probably at a high risk for withdrawal, because most people who don't drink a lot of times are going to be clearly having issues if they're that drunk. So just if somebody says they're not going to withdraw, just make sure that that you have them on your radar if they are blowing that high and they're normal. Or if you see signs of withdrawal and they don't admit to it, then just make sure you're keeping them on your radar. Some of the signs of alcohol withdrawal are anxiety, insomnia, nausea, and abdominal pain, high blood pressure, increased body temperature, hallucinations, fever, seizures, and agitation. They can be sweating. They usually starts anywhere from 8 hours after they've had their last drink. Some people it can start sooner. It usually lasts up to a week or longer. It just depends on the person. If they have tremors, you should call your provider immediately. Opiate intoxication, if they have any of these symptoms going on, you can watch for that. They're unconscious or semi-conscious, and if that's the case, then we need to, if they're like that when they come in, we need to just immediately refuse and have them sent to the ER. Slurred speech, walking crazy, sleepiness, on the nod, their head's nodding, they're nodding off, pinpoint pupils. And if their breathing is slowed down, then we need to start rescue breathing. Opiate withdrawal is also considered a medical emergency, and you should call your provider right away. And your staff should know if you're not on site, they need to do that or notify you if you are. In any kind of withdrawal, hydration is going to be paramount. You're going to want to make sure that you're offering them water every hour. I know some facilities give Gatorade. I don't know I haven't heard of anything else besides Gatorade, or hydration packets. I'm not sure, but just make sure they're getting water at least every hour. And then make sure that if you're monitoring for withdrawal, that you call the provider if they're outside of those parameters on the withdrawal flow sheet. The withdrawal flow sheets are used by the MTPs and the officers, and nurses should be doing the CWA or COWS, whatever their provider, per your provider order. The opiate withdrawal timeline can start anywhere from 6 to 12 hours after somebody's used, or 30 hours for long-acting opiates, and symptoms peak at 72 hours. Nausea, vomiting, cramps, diarrhea, goosebumps, depression, drug cravings. They're also sweating, runny nose, muscle aches, body aches. So watch for all of that. A benzo withdrawal, this is life-threatening as well. And same thing, you need to be notified right away if you're on site. If not, they need to be calling the provider. Common benzos, Xanax, Ativan, Klonopin, Restoril, those are the ones that we see most often. The symptoms for withdrawal and that can start anywhere from 6 to 12 hours after their last dose, and it peaks at 2 weeks generally. The symptoms are listed there: nausea, insomnia, seizures, abnormal body sensations, aches, pains, delirium, muscle spasms, anxiety, panic attacks, depression. So if you notice any of these, you need to contact your provider right away. So our process, when somebody comes in and they say they're going to withdraw, or we notice withdrawal symptoms, we are going to get a urine drug screen. That's the first thing we should be doing, just so we know what's in their system. If it's Suboxone and you have an MAT program, or even if you don't, you need to call and verify a prescription. That way, well, I guess if you don't have to call and verify a prescription, because it doesn't matter. You're not going to give it to them anyway. But just make sure you're, if you do give that you're getting verification of a current prescription. And then after that, you're going to notify your provider, and you're going to get orders. What kind of monitoring do they want? How often do they want it? And then you're going to start, and if they want supportive meds, they'll order those as well. This withdrawal flow sheet is what officers and MTPs can document on this as well. There is a full-on withdrawal protocol that if an MTP is working, that they can fill out before they call the provider, so that they can get withdrawal monitoring started. And of course, nurses use the CWA or the COWS. The CWA is used for alcohol and benzos, and the COWS is used for opiates. So I know that we go over this often, but it's important that we stay on top of this stuff, because again, somebody could die in your facility. You need to make sure you're calling your provider if anything is outside of the parameters. If somebody is tremors and they're already on medicine, you're doing the CWA and stuff. If their blood pressure is crazy, make sure you're notifying your provider. If they're hallucinating, having seizures, definitely need to call your provider. And if it's bad enough, you just need to send them out and then call your provider after. Kind of got to use your clinical judgment on that. Does anybody have anything to add or any questions? Okay, I feel like that's way too fast. It was like 7 minutes. Help me out. Somebody throw a question out, or tell us about a situation you've had to deal with withdrawal. Or
Hey Rosie.
Yeah.
I've been following a couple counties, and one of the things that I see is the issue with documentation between the nurses doing the COWS and CWAs, which should most probably be done in lightning step, but then in your smaller counties where you might have MTPs and officers, they should probably be using the flow sheet and on the piece of paper, and that needs to be scanned into the chart as soon as possible. So when monitoring occurs, we can go in and see those things, because we're suicide and withdrawal and those things that are way up there on importance. Need to kind of take a priority to get things scanned in, so that we can keep an eye on those things. The flow sheet is also available in the lightning step, and I think it's been fixed. I think there used to be something was missing in it, and I think it's been fixed. But if somebody on the outside is trying to help you monitor this, they need to have access to those documents.
Right. I know in my facility, I'm lightning step. My officers are all paper. So I have folders up in their booking office, and it's got the withdrawal flow sheets in it and things like that. So they always have access to that. And of course, I do the COWS and CWA in lightning step, and route them to the provider for signature right away. And of course, if something's off again, I'm going to call. I'm not going to just send that. So yeah, make sure that however your site does it, that your officers and MTPs have access to where they need to be.
And what do we do if the officers aren't doing the protocols?
If they're not doing the withdrawal flow sheet or the protocol itself,
The withdrawal flow sheet.
we need to get on them.
So we should be talking to the jail commander and
Yeah.
let your pedal know, because this is a liability issue, and we're there to help them lower their liability. And again, these are things that our patients are more likely to die in those suicides and those withdrawals. So we need to stress how important they are to our staff, that they follow the training. If they need training, they need to be educated that there's training every first Tuesday of the month. Is that right, Corey? Yeah, that if they need training, and that's I've seen that at different facilities where it's an ongoing battle to get that done on the overnights and over the weekends and things like that.
Yeah, and unfortunately, sometimes you can preach and you can go to the jail commander, and sometimes stuff still doesn't get done. I had a situation here with somebody week before last that was on suicide watch, and in between their 15-minute checks, she almost choked herself to death with padding from the padded cell floor. So I told the officer, I was like, so that's exactly why those 15 minutes are so important. Every 15 minutes, you need to be checking on that person. Because if they hadn't, she would have laid there and choked to death. So that really snapped him. And unfortunately, or we don't want people to have to run into a bad situation before they realize how important that monitoring is in any situation. So just stress how important it is that they get that stuff done.
You can order an egg timer or something like that off of Amazon, but it also shouldn't be 15 minutes on the button, so that the patient can't predict when they're going to happen. Some facilities they make sure that they kind of do them randomly, because if I have 15 minutes to kill myself, they'll take advantage of it.
And I don't know if, they can probably gauge how fast or how often you're coming, but I know that we don't ever alert our patients that, hey, we're going to be checking on you every 15 minutes. We don't ever tell them that, or we'll be here every 30 minutes. So yeah, stagger it out a little bit as much as you can. But we don't want to get too far outside of that 15 minutes, because we need to make sure that we're keeping an eye on them. I know we can see them on the camera, but this woman had pulled the smock up over her face. And if they weren't watching the camera when she was, because they weren't looking at the camera when she was picking the padding off the floor, so they wouldn't have seen it.
Yeah, I had that too, where a girl would peek her head inside the turtle suit and then was doing inappropriate things, and they need to, it's like with their head covered. If you're doing 15-minute checks, they need to come in, they need to uncover their head. They need to ask them to, hey, you need to have that uncovered so I can see you. And look at that as a sign of suspicious behavior when they're doing something like that.
And I tell my officers, when somebody's on alcohol and opiate withdrawal, that they can't just look at a camera and make sure that they're okay. They need to go over there and physically make sure that they are breathing. They can't just look at a camera and say, oh, they're in there, they're sleeping. We need to verify that they're alive.
Yeah. And anybody can start a protocol, right?
Yes.
And who's the only one who can discontinue a protocol or a seawall or cows?
Providers.
The provider. So we need to have that documented in our charting, that we spoke with the provider and how we got that order, because that's one of the things during inspections, they're going to be looking for that stuff.
Does anybody have anything else? Any suggestions, stories?
I might have missed it, but I was going to say, keeping an eye out for the drugs that aren't even necessarily opioids or alcohol, I have seen a lot of really, really bad spice withdrawal. And I know that that's not, one of our, oh, put them on cows or put them on Siwas, but I would probably still have an eye on, especially with, some of the hallucinations that might come with that and like suicide risk.
And see.
And is the spice, is it K2 on the drug test, the urine drug test?
We have
So
no-
if it tests
Yes.
positive, of course, we're going to notify our provider and hopefully they're going to.
They put
give us some
anything and
orders.
everything in that, so there could be chemicals in there that do not show up on the drug test.
And also, like with any kind of withdrawal, the mental health symptoms can last for a very long time. So make sure that you're also monitoring these people's mental health. So. Anybody else? All right, then. Well, if nobody has anything else, I'll let you guys go, and I hope you have a good rest of your week.
All right, thank you, Rosie.
Thanks, Stan.
Sorry I was late.
Oh, you're fine.
I went through the
Appreciate you.
calendar and couldn't get on.
Well, thanks for helping me out.
Thanks, bye.